Hi guys, good evening. I don't know if any one of you is still here because this has been a long day for all of you, and I'm sure you're tired. But we must do these questions, and even if you are not seeing this live, I'm sure eventually you'll see this on the YouTube. So welcome to this deliberation in Obs and Gynae, where we are going to do the discussion of the INI-CET exam, which was yesterday, the November 24th session. And I'm so happy that the PPH question came about bimanual compression or the uterine massage. I hope all of you marked what I have always taught you, that please do uterine massage. All right. It's there in all the medical colleges. So upfront, I'm so happy that that question came. Every time INI-CET will come with one question which will tell us that yes, stick to the core basics, read recommendations which are applicable to the Indian setup. Till things are not accepted by the government of India, the Ministry of Health, it doesn't make a recommendation to be followed blindly. Okay, there are many things which are coming on the on Google, with many things coming in the discussions on the international forums. So many journals coming up, the recommendations, guidelines coming up, but we have to stick to the core basics. All right, come, let's move on and do the next question. And first question that is, and we'll see how many of all of these you got correct. Okay, guys. So a female with a bluish bulge in the vagina and no history of menstruation. That means a primary amenorrhea. A sit-up question, which will, I'm so happy that this one we have discussed many times. That no history of menstruation came with acute urinary retention. What is the diagnosis given in this case? So yes, this is that one question which we know that it can be imperforate hymen, it can be transvaginal septum also. But yes, more common is always the imperforate hymen. So if both the choices are given, I want more information. I want more information in this question that somebody did a per rectal examination. In the per rectal examination, the swelling was a little, the vagina was distended a little higher up. Or if it was totally distending the vagina, then it is a imperforate hymen. If it is just distending the vagina in the upper half or upper three-fourth of the vagina, then it's a transvaginal septum. Both can present with similar symptoms, but this is classically a imperforate hymen. You know that the big distended vagina, if you see the big distended vagina, there's the uterus and the big distended vagina, which is not open, which is full of blood. So what happens? The vaginal opening is closed, but the urethra, which is in front of the uterus, this gets compressed against the pubic symphysis. The sacrum is here. So yes, this excuse me, this vagina will compress, the distended vagina will compress the bladder neck against the pubic symphysis, and that will cause a retention of urine. So this is some diagnosis which we can make on the telephone so many times. My resident will call me and tell me, sir, there's a patient, young girl who's had primary amenorrhea, has come to us with retention of urine. So yes, we will say that, okay, please do a PR, and you'll see that there might be a bulge. All right. So this is how this looks. We know that this is the imperforate hymen, and this will look bluish. If it is a little bit more distant, you will see it will be a little bluish in color. All right. So what have you guys answered? All right. So this is good. This is very simple that all of you know that this is a case of a imperforate hymen. Okay. Let's move on and see the next one. That there was something about this Overa syndrome also written as a choice. Overa syndrome is obviously it's a short form for a very rare kind of a syndrome, which is obviously not the case in this MCQ. That there is a uterine diadelphys, unilateral low vaginal obstruction, and ipsilateral renal agenesis. All right. So when you see that a patient is having this kind of unilateral, vaginal obstruction and ipsilateral renal agenesis, this kind of presentation is so rare that I will definitely not mark. Even a transvaginal septum might be more common, this Overa syndrome. All right. So we will go and mark our answer as imperforate hymen. A is the answer for this MCQ. Come, let's move on and see. Next question, we'll see what are the choices. There are some questions where I have the good choices, some questions the choices have not been recalled properly at all. In fact, I'm taking a class somewhere in Jaipur, and I was talking to the students who were there in the class, and they gave me a lot of questions just before the session started. So I hope you can provide me the correct choices of all of them. Okay, imperfect terminology. Fine. This which of the following is not a germ cell tumor? Now, germ cell tumors, the most common tumor of the ovary are the epithelial tumors, and the next most common are the germ cell. So, epithelial ovarian tumors like the serous adenoma are in older women and they are bilateral. Germ cell tumors are in younger women and they are unilateral. So, germ cell tumors, younger women, and unilateral tumors mostly. Now, germ cell tumors, which of the following is not a germ cell tumor? That is the question here. So, yes, a non obstetric, or actually, it is basically called the non gestational choriocarcinoma. Choriocarcinoma is because of the complication of the vesicular mole. So, that is a pregnancy, gestational choriocarcinoma. Non gestational choriocarcinoma is the one which I don't know why they've written non obstetric. Basically, it is a non gestational choriocarcinoma. Then prepubertal granulosa cell tumor, yolk sac tumor, and dysgerminoma. So yes, the choriocarcinoma is a germ cell tumor, yolk sac tumor is a germ cell tumor, and dysgerminoma is also that. But a granulosa cell tumor, yes, all of you know this so well. Granulosa cell tumor, granulosa cells, they give the estrogen to a woman, and estrogen gives the femininity to a woman. So this is a sex cord. Granulosa cell is the sex cord of a person, of a lady. So these are sex cord tumors. So answer is B. This is sex cord tumor, and this is what we discuss so many times in our classes. All right. So hi, Dr. Malika and Dr. Manipuri Shots. All right, that I'm sure is your name on the social media, but it'll be great to know you personally. All right. So, all of you, I hope you got this correct. The germ cell tumor. Which one is not a germ cell tumor? Granulosa cell tumor is not a germ cell tumor. All right. So, let's move on and see the germ cell tumors. The germ cell tumors are the dysgerminoma, yolk sac tumor, embryonal carcinoma, polyembryoma, non-gestational choriocarcinoma, the one which was written as non-obstetric in the slide, which is wrong. You should write it non-gestational choriocarcinoma, mixed germ cell tumor, a teratoma, and teratoma. Teratoma is the most common germ cell tumor, and teratoma are 10% malignant and 90% are benign. So a benign teratoma is what is actually known as a dermoid. Dermoid, of course, is that tumor which has got bone, hair, teeth, endocrine glands, sebaceous secretions, everything is there. All the germ layer derivatives are seen in this dermoid. So I'm sure you got this correct. Okay. So let's see. What are you guys asking me? Okay, let's move on. In a normal physiology of oogenesis, that is formation of the oocyte, in a normal physiology of oogenesis, which of the following phase is the primary oocyte arrested? So you know that a woman is born with, woman has something like 6 to 7 million primordial follicles, and then she's left with 1 to 2 million at birth, and some 3 to 4 lakhs at puberty. So what happens? This oocytes, they're resting in the prophase of the first meiotic division. So they're resting in the prophase 1. They're resting in the prophase 1. And then till the time they get into ovulating, which is at puberty, they're resting in this prophase 1. Now, which stage of prophase 1 they're resting? Yes. What are you guys going to answer? Come, I'll wait for your answers, since I see a whole lot of you have come and 70 of you have come. All right. So I'm happy that a few of you at least joined, and I'm so happy that you're listening to this. And I'm sure the others are going to see this eventually. So tell me, guys, which stage it is resting? Most of you written as diplotene, correct? So there's diplotene, pachytene, zygotene. Okay, so leptotene, dikinesis. So these 5 stages are there, and it is resting in the diplotene. Now this gives me an opportunity to remind you, at ovulation, when is the first polar body released? I just feel like asking this question. Let's see what are you guys answering. When is the first polar body released? Come quickly. We must do the questions. I'm not going to take a long session of teaching, but at least tell me this one. When is the first polar body released? First polar body. A lot of questions, oocyte, sperms. A lot of questions came to the specialty which I love, infertility. Yes, you guys are not answering. You got tired or what? Come, guys. First polar body. It's released at the time of ovulation, not at the time of puberty. Puberty, yes, a woman starts ovulating at puberty, so technically you're right. But yes, First molar body is released at the time of ovulation. Okay. Right. So let's move on and give you the answers. I'm sure you're all tired. Which of the following is the smallest diameter of the female pelvis? This they want to ask you, obviously, the inlet. Okay. So at the inlet, we have these conjugates. The true conjugate, also known as the anatomical conjugate. The obstetric conjugate means the conjugate which is of obstetric importance, and the diagonal conjugate. So let us see. If you see this pelvis from the side, in this pelvis, the diameter from the top of the pubic symphysis to the top of the sacral promontory, this known as the true conjugate. And the red one, which is from the back of the pubic symphysis, can you see there's a projection? There's a pubic prominence. There's a prominence behind the pubic symphysis. So from the back of the pubic symphysis to the tip of the sacrum, this is the obstetric conjugate. This is the obstetric conjugate. And the one which is in blue is the diagonal conjugate. Now, when we see these three conjugates, the one which is of obstetric importance, why? Because the head of the baby, this head of the baby which is going to enter the pelvis, the anterior posterior diameter, which is suboccipitobregmatic in a vertex presenting part. Okay, the head, when it comes into the pelvis, it comes as vertex mostly, and the diameter of engagement is suboccipitobregmatic 9.5. The transverse diameter is also, biparietal diameter is also 9.5. So this 9.5, when it has to enter the pelvis, then the shortest diameter which it has to encounter is the red diameter or the obstetric conjugate. So this obstetric conjugate better be a little bit more than the 9.5 suboccipitobregmatic. So diagonal conjugate is the one which we can measure. We can do a per vaginal examination and measure the diagonal conjugate. So diagonal conjugate is usually around 12 centimeters. So the true conjugate is diagonal conjugate minus 1 is equal to 11 centimeters. And an obstetric conjugate is diagonal conjugate minus 2 centimeters is equal to 10 centimeters. So by this diagonal conjugate estimation, which you can do in the OPD, you can see diagonal conjugate minus 2 centimeters is 10 here. So the obstetric conjugate is 10 in this patient, and that is more than 9.5. So that's why this head can enter the pelvis. So when this head enters the pelvis, it goes through a curvilinear passage, and that curvilinear passage is known as the curve of Carus. This is known as the curve of Carus. All right, guys. So what else are you guys asking me? Okay. Will RR be enough for FMG? Well, LRR should be a good amount of revision for you if all the LRRs you're seeing. So we are basically trying to help you with all the MCQs which came in the recent time. But at least you should have done some rapid revision, at least, if not done the whole course. So rapid revision in the last, 15 days, you can do for obs and gynae, and you can do the LRR. So that should be good enough preparation if you've done your basic preparation well. Right, guys, let's move on and see the next question. Instrumental delivery is indicated in all of the following except. Come, when we say the instrumental delivery, we all know that we are mostly applying instruments when it is a vertex presenting part and when the biparietal diameter, when this horrible, I have to take out this head and get a better head back. Okay, so when the biparietal diameter has gone through this biparietal diameter 9.5 has gone through the bispinous diameter, which is 10.5. So that time when the biparietal diameter has gone through the bispinous diameter, which is 10.5, then we say this station is +2. So +2 and below only I will do the forceps and vacuum in modern obstetrics. So please, if there is a cephalopelvic disproportion, if the head is too big to go beyond this, then obviously I cannot put forceps and vacuum. You can put forceps and vacuum for mental exhaustion, fetal distress, and prolonged second stage of labor. These are indications, right? If there is a fetal distress in the second stage, I'll put a forceps and take out the baby fast. All right. But in a cephalopelvic disproportion, the head is not able to go through the pelvis. How will you put an instrument? You will obviously, these are the cases where you don't realize that there's a CPD and you apply a forceps and you forcibly take out the head. So you'll crush the head. That sudden compression and decompression of the head will cause intraventricular hemorrhages, and the baby will be born hypoxic, will have birth hypoxia, will have probably cerebral palsy. So when you know that the baby's head is too big, never apply instruments. Go ahead and do a safe cesarean. So it's better to do a safe cesarean than a complicated forceps. It's always the dictum. All right. So yes, you will not do instruments for a CPD. Saloni Raj, your feedback will be taken, and I'm sure the team is reading this. Yes, it's probably a forum for you to give your remarks, and I'm sure the team will see this. All right, let's see the next question. Early onset eclampsia is defined as, what is gestational hypertension, BP more than 140/90, plus proteinuria is known as preeclamptic toxemia or simply preeclampsia. Along with this proteinuria and hypertension, if there is a convulsion, we call it eclampsia. So eclampsia usually happens around term or happens sometimes in labor also. But if it is happening before 34 weeks, what did you guys mark? I hope you marked 34 weeks. All right. So before 34 weeks, if there is eclampsia, we call it a early onset eclampsia. All right. So, Siddhant, if in CPD we use forceps, can it cause penile tears? It will not cause penile tears. It will cause a blast in the perineum. If there's a cephalopelvic disproportion, see, you have to, the head is, I wish I had the pelvis and dummy here. The head is not gone into the pelvis properly because it is too big. And then you push in the forceps next to this big head, and somehow you pull this big head through the small pelvis. So you'll crush the head first. Of course, you'll cause major soft tissue damage and even bony damage in the pelvis of the lady. Okay, there'll be ghastly tears in the pelvis, which sometimes, people used to apply such forceps, and I'll be sitting for 3 hours trying to suture the whole episiotomy and the tear which has happened in the vagina. I'll be sitting in a OT with the patient getting anesthesia for 2 hours, 3 hours. We are repairing the whole anatomy of the lady to make it look that it is all normal. So we've gone through these stages where people have done these antics and tried to take out babies when the head is too big for a smaller pelvis. Fortunately, some babies, most of such babies have done well, but they can get very sick. So please, if you know it is a CPD, don't be foolish to apply an instrument and cause, unnecessary injuries. Right. Yes, you suture tears for 2 hours. Yes, that's what happens, my friend. That's what happens. So many times you'll go on suturing tears. Some of them, they go so high in the vagina that you'll need 2, 3 people to do the retraction. It's a much bigger surgery than a complicated cesarean sometimes. Anyway, so early onset eclampsia is less than 34 weeks. Nobody's answering anything else. Fine, that's the answer which I'm expecting you guys to answer. A lady presented with complaints of a foul-smelling vaginal discharge. Favorite INI-CET question. This has to come in INI-CET at least once a year. Whiff test shows positive results. Which of the following is the causative organism associated? Whiff test, and there are clue cells. This is classically of Gardnerella vaginalis, also known as bacterial vaginosis, and the treatment is metronidazole. All right, guys. So this is the clue cells. This gives us a clue. Clue cells, this vaginal epithelial cells, which is embedded with bacteria. So this epithelial cells, these are, polygonal cells with a dark nucleus, and the cytoplasm is supposed to be clear. Now this bacteria, this cell is embedded with thousands of bacteria. So that's what gives us a clue. What else is seen in bacterial vaginosis? There's an absence of leukocytes in the vagina. The conspicuous absence of leukocytes and abundant clue cells. This is what is going to tell us that the patient has bacterial vaginosis. Treatment is metronidazole. So what is the treatment of bacterial vaginosis in pregnancy, even if it is asked in the first trimester? So even in the first trimester, it is metronidazole because it's a safe drug in pregnancy. All right, guys. So let's move on and see something else. A couple came with complaints of, what are you guys asking? Oh, you're just answering. All right. A couple, excuse me, a couple came with the complaints of infertility. On examination of male sperm count was 60 million, progressive motility of 54%. Female examination was normal with patent tubes and normal uterus. What percentage of such cases are explained by unexplained infertility? Pardon the language, explained by unexplained infertility. There's a lot of grammatical errors. Never mind. So basically, they're asking you what is the percentage of unexplained infertility. So I've always told you the male alone is responsible in 20 to 30% of cases. A female alone is responsible in something like 30 to 40. Some people say 30 to 50% of cases. And male plus female is responsible in 10 to 40% of cases, roughly, okay? But unexplained infertility is roughly around, Novak says 8 to 28%, so we keep telling you 10 to 20% or 10 to 25%, like that we keep teaching you, because the percentage there written is 8 to 28%. So yes, if you really want to know which one I'm going to answer in this, I have a tough choice between 25 to 30%. So if there was this 25%, I'm more likely to answer that one, because that's within the range of what I have been taught. So yes, roughly 25% is the unexplained infertility. Actually, you can go and answer 8 also, but then we always know that MCI exam also they asked you, and in MCI the choice was much better. They said 20%. So yes, then we answered 20%, and now 25% looks like a better answer. And God only helps us with such choices, because they're such close by choices they've given. So what are the choices, you guys, if you can tell me? A is 15%. Some people have answered 15%. I'll go with 25%. I don't know what are the other teachers answering. I don't know. But yes, 8 to 28% is what Novak's Gynecology is saying. So we'll have to go with something like anything between 20 to 25 is what the answer I would like you people to answer. All right. So how many of you answered 25? Did anybody answer 25? Yes, somebody. What are the choices? These are very close by kind of choices. That's why, because all good books are going to give you a range. They give you a range of percentages. They don't give you absolute percentages. So to ask a question which is actually the data is in a range, and then ask questions which are so closely placed, it's not a very good question to ask. But if they've asked you, then I need to know the perfect choices which had come. Never mind. So we'll move on. And you must remember 10 to 30% or 10 to 25% is what is the range of unexplained infertility. It's an often repeat question, MCI and INI-CET as well. Athletic female with secondary amenorrhea came with FSH of 2, LH of 2, prolactin of 20. So prolactin is actually normal. I don't know what were the choices. They look a little vague, but never mind. So LH and FSH is 2 each, and prolactin is 20 nanograms per ml. What is the cause of amenorrhea? So these athletic women, they are the stress of, running all the time and doing exercises. So this exercise related and stress related inhibition of GnRH is the problem of women having amenorrhea. So I don't know what were the choices, but there is a low level of gonadotropin. So we say hypogonadotropic hypogonadism. Best way of saying that. Hypogonadotropic hypogonadism. I would go with answer B. Okay. Normogonadotropic normogonadism. What is happening? Since she's not menstruating, we'll say it is hypogonadism. Okay. If she was menstruating, then there was no problem in answering the A. So she's not menstruating. She has amenorrhea. Obviously, the gonad is not giving estrogen and progesterone. So that's why it is called hypogonadism. Okay. And the levels are a low level. They'll not be less than 0.1 type of levels. So that will be very, very less. So these are the low levels. FSH normally is 2 to 6 international units, isn't it? So the low level of FSH and low level of LH, that's what, was it 0.2 or was it 2? That's what there's a problem here. FSH is 2, LH is 0.2. So I don't know what were the exact choices, but yes, it is basically hypogonadotropic hypogonadism. All of you wrote that. Okay, see, so there is in women who have stress, even people who have anorexia, women who are not eating too well, anorexia nervosa, and women who are exercising too much, and there is a stressful situations like even exams. Yes, so many women with reading perpetually all the time and not having time to exercise, not eating well. Yes, stress related amenorrhea can happen to them as well. So abnormal neuromodulation of the GnRH secretion. So excessive endogenous opioids are secreted, elevation in CRH secretions are seen. All of these three are known to inhibit the secretion of GnRH. I got you this from Novak's Gynecology, but basically you have to know that there is inhibition, stress-related inhibition of the gonadotropin-releasing hormone. Okay, right. Let's move on. Which of the following is not a physiological change seen in pregnancy? I want to hear what you guys wrote. Come, this one, because I've given you a slide on this. I've given you a slide on this in the physiological changes in pregnancy. So I hope if few of you remembered, then I'm sure you got this answer. TSH was also there, Mridul. TSH levels, okay, TSH levels. Were they normal or abnormal? If there was a hypothyroidism, then that can also cause. But athletes won't have a athletic hypothyroidism. No, there's nothing like that. Athletes will have stress-related amenorrhea, which is well-known fact because of the GnRH secretion is reduced. Right. Let's go to the next question. So next question is, which is not a physiological change. So what did you guys answer? Come on, guys. What did you answer? So there's this slide which I gave you that please remember the blood pressure, systolic and diastolic blood pressure in the early pregnancy reduces, and later pregnancy it picks up back to normal. So it does not increase in the early pregnancy. Please remember, blood pressure early or mid pregnancy reduces, late pregnancy BP get back to normal. So that's the answer to this MCQ. Which of the following is not a physiological change seen in pregnancy? Good, some of you got it correct. I'm happy. So heart rate increases. Yes, a heart rate increases and stroke volume increases. Heart rate increases, stroke volume increase in pregnancy. Cardiac output also increase in pregnancy. But respiratory rate is no change. Please don't say respiratory rate increases. Williams Obstetric is very categorically writing that respiratory rate is not changed. Okay. This came in MCI exam long back. Mean arterial blood pressure reduces and peripheral resistance reduces. These two things will reduce. So when does the blood pressure, heart rate, and cardiac output, when does it come back to normal? It comes back to normal by 10 days, by the 10th day of delivery. After 10 days of delivery, it comes back to normal. All right, guys? Chalo. Which of the following is not a quadruple test marker? I mean, outright simple questions when they come in INI-CET, you always think that you made it, isn't it? So yes, you know that it is unconjugated estradiol. It is alpha feto east unconjugated estriol. Oh, then there are two wrong answers. Anyway, what did you guys write? I didn't see that the first choice is estradiol they've written. Anyway, yes, it's unconjugated estriol. It is obviously, if you really go by what is written here, it has to be A and D. But it is basically, they wanted to ask you dimeric inhibin A is the correct choice. So this is definitely the answer. Of course, they have to write E3. That is what is the problem here. This is not properly recalled choice, isn't it? So technically, even A is wrong in this question given. All right, guys, given to you. Yeah. Mridul, you're correct. Mridul, you're correct. So let's not waste too much time on this. Was there a question on active management of third stage of labor? Because just now these two students came to me from one of these centers in Jaipur, and they told me that so there was this active management of third stage of labor, and there was this uterine massage thing there. And bimanual compression, uterine massage, both choices were there. I don't know, cannot be two different choices, it means the same. So what was the question, guys? What was the question, guys? You must tell me that. What was the question about active management of third stage of labor? Which of the following is not done? I think it must be that. So please, I hope each one of you wrote that bimanual compression, a gentle uterine massage is done. I'm seriously hoping you did that. I hope you did not write that uterine massage is not done. I hope you did not write that. Seriously, I showed you so many places. I've shown you proof. So many live classes I've shown you that, and I have so many times in PrepLadder forums I've told you that uterine massage is done. Every labor room in every medical college in the country, they have these protocols which are stuck up, and they have said, please do uterine massage. So what is not included? Bimanual compression not included. Anuj, I'm not happy with that answer. Please, uterine massage is a must. Please. The only thing which is off, let me help you once more. Okay, there is oxytocin given, uterotonics, correct? And then there is control cord traction. And then there is, I'm so sorry, before that there is delayed cord clamping. Delayed cord clamping, control cord traction, and uterine massage. These are the four things we say are seen in the active management of third stage of labor. And out of these, oxytocin, control cord traction, and uterine massage, these are a must. Delayed cord clamping is the least important. It is given very straightforwardly in your Williams obstetrics. That delayed cord clamping, you can even do an early cord clamping, because Williams actually says early cord clamping. We in India say please do delayed cord clamping more than 60 seconds, at least a minute. Why? Because we want the babies to gain 1 gram of hemoglobin. So yes, delayed cord clamping increases the hemoglobin of the baby, but it's got nothing to do in the effect in the management of PPH. So the least important component of these four is the delayed cord clamping. So if at all you want to take out something, take out the delayed cord clamping or early cord clamping. But please do uterine massage. I have said it 6 times already in this discussion. Please. All right, guys. All right, guys. So anyway, I'm not going to change that. And please, all of you interns, man, why are you forgetting? Haven't you gone to the labor rooms wherever you've done your internship from? Haven't you gone to the labor rooms and seen that uterine massage is written in all the protocols across the medical colleges? I'm sure it is written. So yes, do not get. See, WHO does say that uterine massage, persistent uterine massage, will require a person who will be now stuck with this person, with this patient who is doing uterine massage. So dedicated healthcare person is required. Yes, I know WHO writes that. If you're reading WHO, I'm also reading that, isn't it? But that is because WHO has to give recommendations not only just for India. It has to give recommendations for people like, countries like Syria, Afghanistan, Somalia, Ethiopia, where there is a crisis of doctors. We in India have enough doctors in most of the hospitals, in the major hospitals. In fact, there's so many of you trying to pass this PG entrance and get into the hospitals and do uterine massage, aren't you? So please, we have always been taught and we have always practiced, and how, I don't know how many thousands of deliveries I've done, we've always done uterine massage, and every hospital follows that. So you have to understand, because you have done your internship in medical colleges, so you will know what we are asking you here. Okay, come, we are not going to see, WHO recommendations are not to be followed blindly. We will follow what is written in our healthcare setups, in our Ministry of Health recommendations. And when WHO recommendations are implemented, then we talk about that. All right. So let's not just see something comes out in some journal somewhere. Please don't follow it immediately. We do uterine massage. Okay, chalo. Manual compression is same as uterine massage. Okay, maybe they're trying to say two different manual compressions from the top, and uterine massage is bimanual. So I hope there is the choices. If you tell me, I can explain better. All right. There was something about the Pap smear. What was the question about the Pap smear? Low resort setting, something like that. My students were asking me. Yes. What was this thing about the Pap smear, guys? Anything? Now I have got just, these are the questions which are properly called. Now there are some bits and pieces I've got. So there was some question about Pap smear. Pap smear is the best method of screening. It is still the method by which we have reduced CA cervix by 70%. And Pap smear is 48 to 62% sensitive. And what else do you want to know, Pap smear? The cost-effective method of doing the screening of CA cervix is VIA. So I don't know what was the question. What is done in low resource settings for a 21-year-old female? Pap smear. Low resource settings. Yes, we do a Pap smear. 21-year-old lady who is sexually active, go ahead and do a Pap smear. It is cheap. It is easily reproducible by a person who's not even a doctor. A nurse can do it easily. A healthcare worker can do it. All right. So Pap smear is that ideal screening test. We know that so well. Ever since your MBBS days, when you've been taught PSM, Pap smear is that ideal screening test, isn't it? Okay. Co-testing every 5 years, Pap smear. See, co-testing is expensive. Co-test is Pap smear and HPV DNA. HPV DNA is not cheap. Yes, HPV DNA will eventually, a lot of my friends are telling that HPV DNA will eventually replace everything once the cost is brought down. So far, it is not a very cheap test. Okay, eventually, that is what is the idea. Unconjugated estradiol tha. तो फिर दूसरे वाले में डायमेरिक इनिबिन ए लिखा होना चाहिए था ना. सो आंसर दो है. मतलब सी यू नो द quadruple test. When you know the quadruple test, how does it matter what is coming in this recall, isn't it? If you know the quadruple test, you know the four bioannihilates which I used. So are you worried about what has been recalled here? You know it so well, isn't it? So there are two wrong answers in the recall which has been given to me. So let's not lose too much of a sleep on that. Okay, fine. Pap smear, there was a question. Now, mitochondria in sperms is in which area? This is what I was given a question. Was this question there? Where is the mitochondria? This is a very, it's a good smart question, I must say. It's a good smart question. I mean, you knew about sperms all the time. You've been reading about it. But yes, you don't register where is the mitochondria. You know the nucleus is in the head. At least that much you know. Mitochondria is in the head, mid piece, tail. Where is it? Yes. What did you guys write? Yes. So one guy, one gentleman, Sam has answered. Sam Potus, President of the United States. All right, welcome, buddy. Yes, mid-piece. Mid-piece has the mitochondria. All right. So this is from Wiki Commons. They have allowed to take picture, Creative Common license. So yes, the mid piece has the mitochondria. All right. So I got this picture, for you guys to correlate well. Then let's see the next question. Pain abdomen. Now this question, reportedly the students who came, they told me that there was a lot of language in this. There was a big question about this. So give me the gist. Who knows this question well? Pain abdomen. 24-year-old pregnant patient. A 24-year-old pregnant patient. 14 weeks of pregnancy is on warfarin. She has a 8 into 6.8 centimeter unilocular cyst with a reticular pattern. Reticular pattern is that fishnet pattern. Fishnet pattern, reticular pattern, basically it means that it is a hemorrhagic cyst. Itna pata hona chahiye. Hemorrhagic cyst. Hemorrhagic cyst is basically that ovary has bled into it, but the cyst is 8 centimeters. Generally, hemorrhagic cysts are around 1.52 centimeters, 2.5 centimeters. I mean, we don't see such big hemorrhagic cysts. So, if there's such a big hemorrhagic cyst, we are thinking in terms of maybe endometriosis, they're trying to tell us. Anyway, whatever it is, the cyst is too big. It is 8 centimeters. 8 and more is known as a big ovarian cyst in pregnancy. So, I don't know what were the question. What are the choices? Yes, what were the choices, guys? Surgery was one option. Yes, I'll go ahead and do a surgery. If that was an option, it's not there in the choices given to me. So, yes, if there's a woman who has got a pregnancy and there is a ovarian cyst which is 8 centimeters. So, if this is that the fishnet appearance like this, if there is a if there is a ovarian cyst, this ovarian cyst, you can very well understand if it is more than 8 centimeters, it can undergo torsion on its pedicle and torsion rupture hemorrhage that can cause a very serious problem in the pregnant lady. She can have even a life threatening hemorrhage. She can have an abortion. All right. So, yes, I would do a surgery. Why not? Second trimester is the safest time to do a surgery, but warfarin was given. So, was there any information about giving vitamin K and then waiting for 24 hours? Because, yes, warfarin action is rapidly, you can use vitamin K to reverse the action. That's what I was, you can see the XA activity also, anti XA activity, it should be reducing. But still, you can, give this vitamin K and reverse the action of warfarin and go ahead and do the surgery. Was there some information about that? It's too big a question to recall, somebody said. Patient was not pregnant. It's P1L1 not pregnant. Oh, P1L1 not pregnant. So, so that changes things. Then what is 14 weeks? Then why not pregnant but 14 weeks? So it doesn't make sense, guys. You mean to say 14 centimeter mass or a 14 week size mass? Uh, so there's just too many things here in this question. So why don't you write this question to me and send it to me at drprassan@yahoo.com? Why don't you do that? And we can always meet at the PrepLadder forum later about this, isn't it? Why don't you send the suggestion on this itself on the chat, and my team is going to pick up the question easily. Pregnancy is there. 14 week size uterus. 14-week size mass. It's a big ovarian mass. That means you to say there's a pregnancy and there's a 14-week size mass. Take out the ovary. Take out the ovarian tumor. We'll try to save the ovary, obviously. Okay, so I think we're going to waste a lot of time about this question. I don't know the warfarin angle. You're not telling me any information. Warfarin angle, क्यों था? Was it because she was pregnant and on warfarin because she was having a, let's say, replaced mitral valve or something like that? So just too many variables which are there in this MCQ. So till I have better information, I can't give you more answers here. But remember, if she is pregnant and the tumor is 8 and more, it is known as a big tumor in pregnancy. And second trimester is the ideal trimester for removing this. And we will remove even if she's asymptomatic because it can become symptomatic later. At least keep that carry message from this question. Okay. So what else do we have? Ruptured ectopic pregnancy. What not to do? What not to do in ruptured ectopic pregnancy? There was one question about that. Again, the choices have not been given to me. So, ruptured ectopic pregnancy, what not to do? Of course, you'll work fast, you'll do resuscitation, and you'll plan a surgery. If the patient is stable, we can do even laparoscopy. If it is unstable, we always do laparotomy. What not to do? Somebody was saying some methotrexate was a choice. So obviously, ruptured ectopic pregnancy, no methotrexate business, no methotrexate business because methotrexate is given for patients who have methotrexate patients are for unruptured ectopic pregnancy. All right. So, what are you guys answering? Methotrexate in shock. Yeah, doesn't make sense. Methotrexate for emergency management of ectopic pregnancy is nonsense. So, you guys know this answer very well. Hemorrhagic was because of warfarin, Anuj Sharma. Yes. If it is a non pregnant patient and there's a hemorrhagic cyst of the ovary because of warfarin, then I will do conservation. Correct. Then I'll not remove it. That's a different question altogether, my friend Anuj. You asked me a different question. A woman is not pregnant, she's on warfarin, and now she has a hemorrhagic ovarian cyst. I'll stop the warfarin or reduce the warfarin, see the anti-XA levels, and reduce the warfarin dose, and I'll wait for this hemorrhagic cyst to get absorbed by the body. Because hemorrhagic cyst in a non-pregnant woman, many women have hemorrhagic cyst, and we don't touch them at all. See if it is a fishnet appearance, it's a hemorrhagic cyst, and a hemorrhagic cyst you don't have to remove if it is a non-pregnant patient. In a pregnant patient, it's a different ball game altogether. Okay, so good. Now we have discussed all the options. Okay. Question was Paravan Liven woman, known case of heart disease. See, now the warfarin comes in. Heart disease means there were some mitral valve problems and 14-week size mass. Dr. Puneet, we need somewhat more information, but yes, pregnant patient, ovarian tumor, warfarin, and there's a hemorrhagic cyst which is quite big. A big hemorrhagic cyst can be a problem. Suppose it ruptures, patient can bleed a lot in the abdomen, and that can cause an abortion also. Okay, so we will think in terms of surgeries when a lady is pregnant because even an asymptomatic cyst can become symptomatic when it is a big size. So, vigorous baby cord clamping. Do we have to do delayed cord clamping, early cord clamping? So, that was the question. So, if the baby is vigorous, that means the baby is active and having a good breathing. So, is there a contraindication to do a delayed cord clamping? There was some question like that. So, what are the question, guys? Guys, vigorous baby cord clamping. What was the question asked? No, so you're not telling me. So I think then we'll let it go. If a baby is vigorous, and then what is that? Okay, you're saying something. Delayed cord clamping done. In which condition you will do delayed cord clamping? The baby is vigorous. Yes. If the baby is crying well, has got no birth hypoxia, birth asphyxia is not there, we'll go ahead and do a delayed cord clamping. That's fine. Term and preterm, can we go for delayed cord clamping? Yes, obviously. If the preterm baby is sick, then we will not do it. Preterm baby is crying well, vigorous, like they said, then you can do delayed cord clamping. That's fine. Right, guys. So that's the MCQs which I have. And if you have anything else, you can ask me. I'm still waiting for you guys to ask me some questions. Immediate registration was also included in the options. Early onset eclampsia, we have done, Raj. That question we've discussed earlier on in this discussion. We started at 9 sharp. Anything else you guys want to ask me? Methotrexate, immediate registration also included in the options. They just active managed third stage labor. There was bimanual compression and there was also uterine massage. I mean, like, you're asking me to choose between bimanual compression and uterine massage. Yes, gentle uterine massage is done. Okay, bimanual compression, if you really ask me, can be a little bit careful. It can be a little bit painful if both the options were there. Okay, if both the options were there. Guys, I think we'll have to call it a day then. I think you can all, relax from all the long discussions you had after the exams. And I'm sure that we'll be meeting in multiple other forums. And I've given you my email where you can always be in touch with me. Your big exam, the NEET, is coming, and we have to prepare for that. So there are multiple areas where PrepLadder is trying to help you, and especially if you are of a subscription. Otherwise, also we have a lot of things coming on the YouTube. So I hope you can all gain with us and finish your course early for the NEET exams. All right, and so. Puneet, which stage is not included in active man's third stage of labor? I mean, like, you start when the shoulder comes out. So it is in the delivery of the fetus, the second stage onwards. That is when you're doing the delivery of the baby. That is second stage. From that stage onwards, you're trying to manage the uh, PPH. So I don't know what you're trying to ask me, my friend. If bimanual compression and uterine massage both is there, then I would say that do a gentle uterine massage and prevent a bimanual compression, because bimanual is putting both the hands inside and one hand in the vagina, one hand on the abdomen, and you can theoretically introduce infection. So do a gentle uterine massage, that is fine. Bimanual compression, if there's a choice between these two, I mean, so seriously now, if both the choices are given, so it is proving what I say, that you must do a gentle uterine massage, which will promote contractions. Yes, bimanual massaging is more painful than just a simple uterine massage. So yes, if to choose between these two, then I have answered that. Go ahead and write that bimanual compression will be more painful than just a gentle uterine massage. Then you can take that answer. Right. So I think that does it for all of us today. Yes, that was a question. So that satisfies a few of you. So thanks for staying back so late. And please keep reading regularly and be in touch on the PrepLadder forum for more further updates. All right, guys. Thanks so much and bye bye.